In today's session, we'll be talking about the GIT, the gastrointestinal tract and the renal disorders, the most common disorders affecting these systems, and how these complications or the side effects of the medications which are given help or hinder the progress of the treatment of a dental of any dental procedure, and how it can affect the dental physician as such. So moving on to the first system, that is a GIT system. The most common disorders which affect the GIT system can be broadly classified into three parts depending upon the location wherein this particular disease is found. Based upon the upper digestive tract, the lower digestive tract, and the diseases which affect the hepatobiliary system. Now we'll be combining all these particular disorders of the various tracts, and we're talking about the most commonly found or commonly encountered disorders in the general population. The first being the gastroesophageal reflux disease, also called as GERD. Now this is the most common of all the GIT disturbances, and found in almost 90% of the general population. Now what is this GIT? This is basically a reverse progression of the food or the chyme, which has to go from up to down, but here what happens is the food comes from down to up. That means to say it is a passive movement of all the gastric contents, also called as the chyme, from the stomach into the esophagus. Now we all know as the food progresses into the stomach, the first and the foremost chemical which it encounters is the acid content of the stomach. Now this acid is basically responsible for the digestion of the food which we take in. Now, during this process wherein there is a passive movement of the food from the stomach into the esophagus and ultimately into the mouth, this food is in the partially digested state. That is to say that the content of acid mixed with this food is on the higher side. Now, we all know the corrosive effects of the acid and its disastrous effect on the mineralized structure in the oral cavity. So if you see the clinical features, all the clinical features are basically to do something to do with the acid content within the food. Now the heartburn, which is the most important or the cardinal symptom, that is primarily due to the acid content which is found in the stomach. The mucosal injuries, again because of the corrosive effect of the acid which is found in a higher content, that erodes away the mucosa, which is most sensitive in the inner lining of the GIT tract. Now because of that we have depending on the various locations, there is inflammation because of this acid, and accordingly we have esophagitis, a little more severe state which progresses into ulceration and may also progress into a perforation. Now because of this heartburn there is a referred pain which is commonly seen, and because of that heartburn we have a chest pain, and because the esophagus and the food tract is partially or completely damaged because of the acid content, we have dysphagia, or which is also called as difficulty in intake of food. Now other GIT complications, because of the repetitive nature of this particular disease, repetitive abuse to the GIT lining and repetitive healing of this particular esophagus or the inner lining, this constant process of repair and healing and damage to the inner lining may progress this particular state into a more pre-malignant or malignant conditions affecting the upper GIT tract. Now how do we manage? Simple. Basically all the problems of arising due to GIT is basically because of the acid content. So counteract that particular acid using this H2 receptor antagonist, which reduces the production of acid within the stomach, or it counteracts the acid content within the stomach. Or the proton pump inhibitors. If we look back into the previous sessions wherein I've talked about the proton pump inhibitors, it basically inhibits the channel or the process by which the acid is produced into the stomach. Now this proton pump is basically responsible for the maximum responsibility lies with the proton pump channels, which pumps in the acid from the gastric lining into the lumen of the stomach. So if you can inhibit that particular channel, obviously the production of acid is reduced. Also pro-motility drugs, basically this is a passive movement from down to up. So it's a reverse process of the natural GIT tract. So if we can inhibit or hinder the process of this food coming up back into the esophagus and to the oral cavity, and help the foot to go in its natural direction. That is to help in the motility of these of the foot or the chyme. We can like in scissor pride, we can inhibit the effects or the complications of this GERD. So what are the oral considerations? We all know because of this partially digested food which is exposed to the oral environment or the oral microorganisms, there may be partial or full degradation of this particular food, which results in a foul taste, also called as dysgeusia. Now, because of this acid, because of the erosion capability of this acid, the enamel and the dentin generally erodes away, and on a long period of time, and say about since it is chronic in nature, in a longer period of time, there is natural erosion of these protective layers, and the pulp and the dentin is exposed to the external environment. Now, this results in dental sensitivity, which may progress into a more severe erosions, leading into pulpitis and natural and periapical infections, and so on and so forth. So, also the another thing which we have to take into consideration is the medications which are given in cases of GERD. Most common medications which are given are H2 receptor antagonists, which are the most potent of all the drugs to counteract this GERD complications. But because of these H2 receptor antagonists or antacids, there is a chance of the person getting into developing xerostomia, which is, and the further complications of xerostomia, and these particular effects of xerostomia have to be counteracted while taking treating GERD patients. Now, to minimize this particular acid effect and to minimize this dysgeusia or the foul breath within the mouth arising because of this acid content, we have to take into consideration the usage of mild baking soda mouth rinses, which counteracts the effect of acid. Now, also because of the erosions which is seen because of this acid, we can use fluoride applications, topical fluoride applications, which result in the remineralization of enamel and the dentin. Now, also the side effects of other receptor antagonists is general complications that include CNS problems resulting in lethargy or confusion or delirium, which has to be taken into account while treating middle-aged to older age patients. Moving on to the other most common disorder which affects the GIT is the hiatus hernia. Now, hiatus literally means an opening, a small opening. Now, where is this opening found? This hiatus is found at the juncture between the between the esophagus, that is the food tract, and the opening of the stomach. Now, this particular location is of more importance is because the diaphragm passes through this particular point. So it basically divides, this hiatus basically divides the body parts into the upper region, the thorax region, and the abdominal region. Now, what happens in few cases is this particular opening becomes weakened, or this particular hiatus becomes enlarged, thereby allowing the food contents or the partially digested food contents to come up or regurg into the esophagus from the stomach. Now, what is the etiology of such of this kind of disorder? It's basically because of hereditary factors. It runs through the family, and also maybe because of general conditions of the general daily basis things which we undergo, such as exercising or weightlifting, wherein all the conditions wherein there is a creation of a negative pressure in the lower abdominal region, wherein it enforces the contents within the abdominal region to push up into the upper regions. That produces or weakens this particular hiatus hernia. Now, continuous exposure to such type of negative pressures or a chronic habitual effect of this particular creation of negative pressure results in a weakened or an enlarged hiatus, such as we can see in weightlifting, wherein there is negative pressure created from the lower abdominal region pushing up the contents into the upper region. Also, while chronic straining during passing stools, we also notice that there is a creation of an immense amount of negative pressure which creates a difference in pressures between the upper thorax and the lower abdomen, forcing these contents, pushing against the hiatus, thereby enlarging it. This chronic enlarging of this particular hiatus results in pushing of these food contents back into the upper cavity. Now, how do we manage it? As in with the GIT, the basic problem which lies with partial digested food is the acid content. So, deal it with the antacids, contract the effects of this acid effect, and you can thoroughly manage these patients. Now, as in with GIT, we can also use H2 receptor antagonist that basically inhibits the production of acid or inhibits the production of histamine within this within the stomach lining. Also, in severe cases, we may also go for surgical correction. What are the oral health considerations? As spoken previously, just like GIT, all the side complications or the complications, side effects because of the medications, because of the acid effect are also seen over here. Like and most commonly used medication for hiatus hernia patients are your H2 receptor antagonists, which again has a common side effect as in with GIT in producing xerostomia. And because of xerostomia or the dry mouth, all the subsequent side complications, be it the infections, opportunistic infections, or the dental caries or production of class 5 dental caries, which is specific or typical to dry mouth patients, all these are seen in hiatus hernia patients. Apart from this, the importance of this particular disorder for a dental physician is coupled with all the dental treatments which are meted out to the patient. We also need to take care of the side complications of these H2 receptor antagonists, which the patient is on a long-term use. So, long-term use results in more chronic kind of side effects which have to be taken care of, such as taking in of artificial saliva. Because of the dryness, there is continuous dryness. There is the salivary glands become enlarged to produce more amount of saliva to lubricate the inner lining of the oral mucosa. Now, on chronic activation of these salivary glands, the amount of saliva output gradually decreases. Therein to say, the normal amount of saliva is not present in hiatus hernia patients, wherein it has to be substituted with an artificial saliva. Now, alcohol-free mouthwashes, we all know that the alcohol content slightly produces a burning sensation in the oral mucosa, especially if it is a dry environment. Now, since these patients have xerostomia anyways, so we have to use alcohol-free mouth rinses for these kind of patients. Now, as I said, the most typical feature of a patient with extensive caries in his mouth and a patient with caries resulting due to xerostomia is a typical presence of class 5 caries, which is not normally seen in the general population, but it is specific to patients suffering from xerostomia. So the next common disorder affecting the GIT is a peptic ulcer disease, which in simple terms to say that it is a most severe form of an erosion which is seen in GIT or in previous kind of disorders. It is basically a benign ulceration which affects the epithelial lining of the stomach or the gastric lining, partially or fully involving all the layers of the gut. So depending upon the type of ulcer which affects or the severity or the frequency with which the patient comes up with this particular peptic ulcer disease, it may be involving only the few layers of stomach lining or the gut lining, or the total layer, all the layers of the stomach lining. The etiology being it is predominantly genetic. Also, as in we see there's a strong link between the anxiety or the stress levels and the production of acids, and this results in peptic ulcers. And also, the most common etiology being the H. pylori infection, which although not very commonly seen in the general population, but still is one of the most important etiologies for peptic ulcer disease. The most common symptoms, as in with any kind of ulcer, we have pain associated. There is if the ulcer involves all the layers and it goes in and involves the whole gut lining, there might be perforation between the GIT lining and the adjacent structures, and all the complications resulting because of the perforation can be seen in this particular disease. Predominantly, since since the ulcer involves all the layers, there is a huge amount of blood loss. There may be hemorrhage of this blood into the adjacent structures or the adjacent cavities, and vomiting of this gross blood. And because of the partial degradation of this blood into a more brownish or blackish discoloration and its passage into the stools appear black or tar-like. That gives an indication as to some kind of bleeding within the GIT tract. And also because of the huge amount of blood loss and its passage into the stools, we have iron deficiency anemia also. Now the management, primarily it is to counteract the etiological factors by giving anti-anxiolytics or antidepressants or sedatives to reduce the mental stress or the tension. And also the antacids, again the common antacids which are used to neutralize the acid found within the stomach lining. And also other kinds of medications which can be used to reduce this production of acid or to counteract the already present acid which is within the stomach lining, such as this proton pump inhibitors. The most commonly one used is omeprazole, and also again the mainstay of any kind of acid counteracting effects, that is a H2 receptor antagonist, can be given in these particular patients. Now the oral health considerations, primarily because of the huge amount of blood loss because of this perforations, we have iron deficiency anemia which resulting from the gastrointestinal bleeding areas. And also the dental erosion, primarily because of the acid production or the which can generally erode away the enamel or the protective layers of the dental structures, thereby resulting in sensitivity and progression into pulpitis. To also, as said, the mainstay of medications which is H2 receptor antagonist, the most important complication or side effect of these medications is xerostomia, so thereby resulting in a hyposalivation and its subsequent sequelae. In dental patients, predominantly in the older age or the middle age patients, wherein we generally meet out, there's a need for giving out dentures. Now the basic effect of a basic principle upon which these dentures retention is based on is the adhesion between the salivary component between the oral mucosa and the denture acrylic base. So because of xerostomia, there is difficulty in denture wearing, especially in these patients, wherein to counteract we have to give an artificial saliva. Also, additionally, because of these antacids, the most common contraindication of usage of antacids is in patients who are on long-term antibiotics, because these antacids basically contains calcium and magnesium and aluminum salts, which bind with the antibiotics which the patient is taking, and thereby reducing the amount of antibiotic dosage being absorbed into the systemic circulation, thereby reducing the effect or the efficiency or the potency of these antibiotics. So it has to be taken care that people on antibiotics are generally you avoid giving antacids because of the non-synergistic effect by which the antacids and the antibiotics act. The most common disease affecting the GIT is the Crohn's disease. And the Crohn's disease, although very rare in the general population, its area of interest for dental physicians are its oral complications, which I'll be speaking about. So what is this Crohn's disease basically? It is basically an inflammatory disease of the small or the large intestine, which involves all the layers of the gut. So starting from the inner layer up to the layer closer to the surrounding cavities, all the layers are involved, all the layers are inflamed, and subsequently all the types of repair and healing process which has to take place with any kind of inflammation are seen in this case. Now depending upon the extent to which this inflammation is present, we have a non-perforating type and a perforating type. Now the perforating type, as the name suggests, there is a perforation between the GIT and the surrounding cavities, which is a more severe kind of manifestation of Crohn's disease. The other type is a non-perforating type. Name suggests it is a non-invasive type. recurrence is slightly on the lower side, and the progression of this disease is also slow. So what do we find? What are the signs and symptoms of this particular disease? As in with any kind of inflammation, since the gut lining is, all the layers are totally involved because of this inflammation, we have GIT disturbances, and since it is also associated with inflammation, we also have fever and fever associated with it. Because of the disturbance in the lining, we also have loose stools. Also, all the subsequent sequelae because of any disturbance in the GIT lining are seen over here. And apart from this, there appearance of a small aphthous ulcers within the GIT lining because of this disease. Since it is a chronic disease, this Crohn's disease is a chronic disease, this constant repair and healing process which takes place. The healing takes place via fibrosis or muscle hypertrophy, which actually reduces the lumen of the gut. So that is the most important complication on a long-term basis of this particular disease. Now, because of this repair inflammation, there is improper absorption of the required minerals from the gut. As you can see, there is a deficiency of all the main minerals which are absorbed within the GIT, and also the electrolyte abnormalities. All these are have to be absorbed and are absorbed within the GIT lining, and because of the inflammation, all these are not absorbed and passes through the stools or the urine, and thereby resulting in deficiency of these electrolytes or minerals. So moving on to the health considerations, the most important finding is the presence of RAS, also known as recurrent aphthous ulcers. Depending upon the frequency or the severity with which these ulcers present within the oral mucosa, coupled with the signs and symptoms or the typical signs and symptoms of GIT disorders, we can suspect a case to be a Crohn's disease case. Now, apart from this, the most typical presentation of a Crohn's disease patient is a presence of a cobblestone pattern of appearance on the oral mucosa, wherein to say the oral mucosa is transversed by innumerable number of parallel linear ulcers which are bordered by hypoplastic areas, so to give a classic picture of a cobblestone pattern. This is typically seen in Crohn's disease patients. Now, apart from that, there is also diffuse swelling of the lips and faces, not most commonly, but it is also found. But the typical feature of this presence of inflammatory hyperplasias, along with the recurrent aphthous ulcers, and histological confirmation can pinpoint this particular disease as Crohn's disease. Now, if we take the histological picture of Crohn's disease, we find a minor salivary gland duct pathology, and also there is granulomatous changes within the oral mucosa. So, to manage these particular patients, it's basically a conservative kind of a treatment, wherein because of this hypoplastic areas, the general health of the oral mucosa or the oral cavity decreases. So, to manage you have to manage the oral health, which is a primary mainstay of this particular treatment of this particular disease. And apart from that, dealing with the GIT complications basically reverses all the effects which are seen in the oral mucosa. So a patient which comes in, who comes in with typical GIT complaints with RAS and the cobblestone pattern of oral mucosa, if we actually treat the GIT complications, there is no need for an extra dealing of these oral complications, because it reverses back to its normal state once the GIT complications are taken care of. So also, this is a chronic disease, and generally the patients are on corticosteroids if they have already been diagnosed with Crohn's disease. So a suppression of this hypothalamus pituitary axis, that also called as HP axis, has to be taken care of. And also the timing of dental treatments have to coincide with the suppression or the upgradation of this HP axis. So since the patients are on corticosteroids, excess amount of stress can trigger this HP axis suppressor, which the dental physician has to take care of. The other most common disease affecting the GIT, especially the lower GIT, is the jaundice, which which basically is actually a misdiagnosis. It's not basically a disease, but wherein a conglomerate of diseases produces this kind of sign in the general body, which is known as jaundice. Now, this jaundice or icterus is basically a sign, as I said, which results from excess bilirubin, that is a breakdown of your blood or from other causes in the circulation, and this accumulation of bilirubin in sensitive areas or in tissues such as your the mucous membrane or the bulbous part of the conjunctiva or the sclera of the eye. So this, because of the excess amount of bilirubin, there is a yellow discoloration which is seen, and this particular sign is known as jaundice. Now the etiology being, it could be primarily of three types. The primary, the most important kind of etiology being hemolytic jaundice, wherein there is this excess production of bilirubin is by hemolysis of the red blood cells, which is one of the most important cause. Apart from that, we also have obstructive kind of jaundice, wherein the hepatobiliary tree is basically obstructed. So there is excess accumulation of this bilirubin, and there is no subsequent excretion or excretion of this bilirubin pigment. The third or the more rarest kind of etiology being the liver parenchymal diseases, that is the hepatocellular kind of jaundice. Now, what are the oral health considerations? Basically, if we take into consideration the etiology, as I said, the most important kind of etiology or the most important kind of jaundice is the hemolytic kind of disease, where jaundice, wherein there is destruction of the RBCs. So destruction of RBCs results in anemia. Thereby, we have angular cheilitis, primarily because of this anemic condition of the patient. We have glossitis, again because of anemia. We have mucosal pallor, again because of anemia. So all the complications arising because of this hemolysis can be seen in the oral health. Also, the yellow pigmentation of the oral mucosa, that is a general sign, as in with the sclera and the other parts of the body. We also see association between the appearance of jaundice and Sjogren's syndrome, which is an autoimmune disorder. Now, in Sjogren's syndrome, since it is coupled with jaundice or a liver disease, there is gradual salivary gland dysfunction, which is seen in Sjogren's syndrome, thereby resulting in the gradual salivary gland enlargement and also xerostomia. Now, all these complications again arising because of this salivary gland dysfunction arising due to Sjogren's syndrome can be seen in this particular patients. Apart from that, as I said, there is pigmentation of the oral mucosa also. The most important complication, although, is the feasibility of doing oral surgical procedures in jaundice patients. As we all know, because of this obstructive jaundice, there is vitamin K malabsorption, which is one of the most important functions of this liver. Now, we know that vitamin K is one of the most important factors responsible, or vitamin responsible for the absorption or the synthesis of coagulant factors. Now, because of the lack of absorption of vitamin K, there is a lack of these coagulant factors, sufficient amount of these coagulant factors within the body, which directly results in excessive bleeding. So, in case of any elective dental surgeries or minor surgeries or emergency surgeries, the dental physician has to take care of replacing this lost vitamin K prior to the start of the dental surgery. That is by giving it parenterally. Normally, vitamin K injections is normally given IM, which are with a dose of 10 milligrams prior to the any surgical procedure. So that being one of the most important consideration which has to be taken care in patients with jaundice. The last more common kind of disorder affecting the GIT is the liver cirrhosis. Basically, cirrhosis is not a single disease or a single process. It's basically any kind of abnormality or the liver disease which results in which directly ends as a cirrhosis. It is an end result, as I was saying, with a variety of conditions which produce chronic inflammation of the liver cells, the hepatic system. So the symptoms are basically a result of this particular hepatocellular dysfunction or portal hypertension, again because of the unique circulation system which is present associated with the liver, or which it can be a combination of both this hepatocellular dysfunction and portal hypertension. So what are the signs and symptoms? As in with any common signs and symptoms associated with liver dysfunction, that is your malaise, your dyspepsia, your anorexia, nausea, all these are common complications of any liver disease. Apart from that, abdominal pain, and most important kind of oral complication which can be seen is the increased amount of pigmentation, also called as hemochromatosis, primarily because of hepatocellular destructions. Now this can be manifested within the oral cavity also, the pigmentation, hemochromatosis. Apart from that, we also know that liver is the primary center for production of coagulant factors. So in cirrhosis, wherein we have hepatocellular dysfunction or there's loss of a destruction of the liver cells, there's also inability to synthesize these particular coagulant factors, thereby resulting in excess bleeding. So all the protocols, as in discussed in the previous session, which are applicable to patients on bleeding or clotting disorders, have to be applied in liver cirrhosis patients before attempting any elective dental surgeries. So all the BT-CT, as commonly known, the blood bleeding time, clotting time, also the INR, all these factors have to be taken care of before touching these patients. And also we also have the detoxification factor, which is one of the most important functions of the liver, is hampered in these kind of patients. So basically toxic or partially toxic drugs or antibiotics which are generally given to the population after a specific kind of dental treatments have to be avoided and replaced with alternative kind of antibiotics which can be easily excreted out. So moving on to the next system, that is your renal system. The importance of the renal system lies in the fact that kidneys play a variety of roles, starting from its endocrine function, its blood related function, hemopoietic system, the homeostasis, the basic acid-base balance or the electrolyte balance or the filtration of blood. It has a variety of functions wherein it affects the overall general health. So any disorder which affects the renal system has a multi-pronged effect, wherein the symptoms can be seen in all other systems, and oral mucosa is no exception to that. So as you can see, the basic functions of a renal system starts from the acid-base balance or homeostasis up to the endocrine functions. It has a role to play in each and every other system of the general of a general human being. Among these renal disorders which affects the general population, the most common being the renal failures, be it the acute renal failure or the chronic renal failure, which accounts to about 60 to 70% of all the renal disorders which affects the general population. Now, to define an acute renal failure, it is a clinical syndrome which is characterized by rapid decline in the kidney function over a period of days to weeks, ultimately resulting in azotemia. Azotemia is basically increase in the nitrogenous base and byproducts within the blood. Also, a term can be used for that is the Bunn term, which is indicates a level of urea or the nitrogenous base within the blood. So severe azotemia is basically increase in these nitrogenous base and byproducts in the bloodstream. So the clinical course is a three-pronged course wherein it passes through three different stages. The first stage being oliguria, wherein the urine volume is less than 400 milliliters per day, which is the first stage of any acute renal failure patients, followed by diuresis, wherein the urinary volume reverses itself. That is, there is greater amount of urinary output, more than 400 milliliters per day. And finally, there is a recovery state. Now, the etiology being pre-renal, renal or post-renal, or which depending upon the location of this etiology which results in acute renal failure, The most common cause among that is acute intrinsic renal failure, that is within the renal kidneys itself. Now, contrary or somewhat similar to that is the chronic renal failure, wherein it is n number of diseases can cause a renal failure as an end stage disease. Now, this clinical course of chronic renal failure, same as that of ARF, can be divided into three stages. The primary being RRFC, that is diminished renal reserve filtration capacity, followed by renal insufficiency, and finally by uremia or end stage renal disease. Now, what do you mean by this diminished renal reserve filtration capacity? Now, normally, let's say the renal or the kidneys excrete X amount of, say about 500 ml of urine per day, which is a normal excreted capacity of the renal system. Now, during times of excessive stress or mental attention or anxiety, or wherein the body has to undergo excess amount of external factors, there is increase in this particular excretory output, say about to another plus 100 ml, taking it about to 600 ml. Now, this difference between this stressful amount of output and normal output, that is called the renal reserve, which is of huge importance to for the general working of a human being. Now, this particular capacity, or the filtration capacity, or the reserve capacity, is decreased in a chronic renal failure, ultimately resulting in its sequelae. Now, the disorders various, as I said, there are n number of diseases which ultimately result in chronic renal failure, among which the primary culprit being diabetes mellitus. Diabetes mellitus, as you know, affects majority of the population, and as an end stage disease of diabetes mellitus, we can see chronic renal failure, as you can see, which accounts for 44.4. Almost half of the cases of chronic renal failure can be attributed to diabetes mellitus, followed by the second killer, that is hypertension, followed by other less common etiological factors such as glomerulonephritis or interstitial kidney disease or other diseases. Primary being diabetes mellitus and hypertension. And also because of this diabetes mellitus and hypertension, which in itself has a various number of oral manifestations or oral complications, coupled with renal disease, it produces disastrous effect on the oral mucosa as well as oral bony structures. Now, the byproduct of this end stage disease or chronic renal disease is something called as uremic syndrome, which is a inclusion of various number of effects because of this chronic renal failure. Now, this can be grouped into two different kind of symptoms. The first, which is all the symptoms which are related to the regulatory or the excretory system. So, any disturbances in the electrolytes or the minerals or the homeostasis of the general body are included under one group of symptoms. The second one, which basically affects the general health of the being, that is your cardiovascular, GIT, and all other systems wherein in all these systems wherein this renal systems effect is seen. Symptoms produced in these systems are grouped under the second group of symptoms. In totally, this is called as uremic syndrome. Now, as I told, the oral manifestations are one of the most important, very important for the dental physician, and to recognize it is of utmost importance. Along with the primary etiological factors, as I said, diabetes mellitus and hypertension, also because of the products which have to be released and which are not released during renal failure, the complications are seen. As in, we can see enlarged salivary glands. As you know, with the renal system plays an important role in the homeostasis. There is imbalance in the water on the electrolytes, thereby resulting in a decreased amount of saliva because of lack of homeostasis, thereby resulting in xerostomia. Prolonged xerostomia, as I told, results in excessive hypertrophy of the salivary glands. Thereby we see enlarged salivary glands in chronic renal failure. Because of enlarged salivary glands, we have decreased salivary flow. That is a chronic state of xerostomia, thereby resulting in dry mouth. Now, because of the dry mouth, we have no flushing effect of the saliva. We have odor of foul odor, And because of the increase in, as I said, azotemia, increase in the nitrogenous products or the byproducts, we have increase in urea content in the blood or in the serum or in the GCF, thereby the odor of urea on the breath, which results in a metallic taste. Also, this alters the taste sensation, that is also called as dysgeusia. Now, because of this decrease in saliva, we have increased calculus, increased incidence of dental caries, and because of lack of salivary remineralization potential, we have enamel hypoplasia, commonly seen in chronic renal failure patients or patients undergoing dialysis. There is enamel hypoplasia because of the lack of remineralization potential of saliva. Now, if you see, if you even go further, we have dental malocclusions. As I told, the most common etiology being diabetes mellitus, and if you draw up a link between malocclusions and diabetes mellitus, you will see that diabetes mellitus decreases the bone level in the or the periodontal health is drastically hampered in these patients, thereby decreasing the bone level. Decrease in bone level decreases the support of these of teeth. Now, because of the lack of support, these teeth go in different directions, thereby resulting in malocclusion, primarily because of the poor periodontal health. Now, because of, as I was told, poor periodontal health, we have gingival inflammation, that is again seen over here. We also know that kidneys play an important role in the production of coagulant factors or erythropoietin, thereby resulting in petechia or ecchymosis because of the lack of these coagulant factors. Bleeding from gingiva, again because of poor periodontal health, coupled with the increased propensity for the patient to undergo bleeding or the lack of coagulant factors. Now, because of these, accumulation of this sugar-rich blood within the periodontal pockets, coupled with lack of flushing action of saliva, there is rise in the opportunistic fungal infections, as you can see, the candidal infections. So, if you basically draw a link or a flow chart between all the etiological factors, the basic functions of renal system, you can actually list out all the oral manifestations without even trying to by heart it or mug it. So, along with that, so that brings us the end to the oral manifestations of this renal disease. Now, if you draw up a link between these oral manifestations and this effect on the bony structures, or the effect of a renal functions upon the bony structures, you can come up with the radiographic manifestations. As in, we know that vitamin D, the active vitamin D, is synthesized within the renal system, that is your kidneys. So, because of lack of vitamin D, there is a decrease in the calcium level, in the decrease in the serum or the blood calcium level. Because of the low calcium level or the blood level during times of stress, it tries to increase the calcium level by drawing up its calcium level from demineralization of the surrounding bony structures or the mineralized structures. So, thereby you see demineralization of bone primarily because as a body compensatory mechanism to increase the calcium level in the serum or the blood. So, you see demineralization of bone. Because of demineralization, the trabecular pattern gets fuzzy. You have loss of a trabecular pattern, which is evident on the radiographs. We have ground glass appearance, that is a severe kind of loss of trabeculae, wherein it becomes all fuzzy and the bony trabeculae can be rarely seen or hardly seen in a ground glass appearance, which is a severe form of demineralization. Loss of lamina dura, that again because of the decrease in the mineralization of the bony support of the teeth. There is also giant cell lesions of brown tumors. If you recollect, the giant cell lesions are nothing but pockets of demineralizations which have taken place, and if you recollect, the giant cell lesions are basically nothing but huge areas of demineralization which is seen in the jaws and which is filled with granulomatous tissues and blood. That is again a severe case of demineralization, again seen in the later stages of chronic renal failure, evident on the radiographs. Now, socket sclerosis, again because of demineralization. We have pulp narrowing or calcification, again because of the increase in the nitrogenous waste products or the urea content within the blood. there is a precipitation of these urea crystals as pulp stones, which results in pulpal narrowing or calcifications. Now, because of that loss of lamina dura, there is loss of support, you have tooth mobility, at different stages of bone loss, as is evident on the radiographs. Now, you can see this OPG picture, and then occlusal, anterior occlusal, which shows the loss of a bony trabeculae in this particular area. This fuzzy bony trabeculae, as you can see in this OPG also. You can also see in these anterior occlusals, wherein you have fuzzy trabecular pattern over here, loss of bone in the anterior region, as is evident by the bone loss over here. There is also widening of pedial space, loss of lamina dura, again loss of bone. You can see the enamel hypoplasia, which is most commonly seen in an end-stage renal disease. You can also see in this panoramic radiograph, wherein you can clearly make out the socket sclerosis seen in this particular patient with end-stage renal disease. So basically the management is two-pronged, one being the conservative therapy, which is basically done to delay any kind of renal complications seen in these kind of patients. The other is the renal replacement therapy. You either replace the lost fluids or the lost electrolytes, type of diet is changed, the basic habit or lifestyle which has an effect on an excess pressure on the kidneys, on the renal system, is basically avoided. Now, as in there is no clear guidelines when the renal replacement therapy has to start, but normally it is said that when the creatinine levels or the serum creatinine levels is more than 6 milligrams per deciliter, or the glomerular filtration rate of the renal system decreases so much that it becomes less than 4 milliliters per minute, that is when you go in for a renal replacement therapy or a dialysis therapy. As you all know, the dialysis therapy is normally done in two ways: the peritoneal dialysis and the non-peritoneal type of dialysis. Depending upon the type of, depending upon the comfort of the patient, the cost, the convenience of the feasibility of the patient, either of the two types of dialysis is taken forward in these particular patients. Now, among these renal patients, especially with the patients with chronic renal failure, it is most important, or most of the laboratory technicians or the physicians have their focus on something called as beans. Now, this beans is a short form for each letter of beans holds for one particular parameter, wherein the levels above or below this particular parameter, the patient is taken into a renal replacement therapy. The first B in beans stands for the blood pressure, wherein it has to be maintained below 130 by 85 millimeters of mercury. Anything above that, which cannot be reduced by using medications or any other alternative therapies, the person is taken into a dialysis treatment. Now, the E stands for erythropoietin. As you know, erythropoietin is produced by kidneys, and because of the decrease in erythropoietin, many of the complications take place. So, hemoglobin levels whenever below 10 to 12 grams per deciliter, the patient is taken into dialysis. Now, normally it has to be maintained from 10 to 12. A, it is access for dialysis. As I said, whenever the serum creatinine level is more than 4 milligrams per deciliter, or GFR, the glomerular filtration rate is less than 4 milliliters per minute, dialysis is a must. N stand for the nutrition status. Now, the diet chart of these particular patients is very much different from the normal population, because any kind of diet which has an excess pressure or excess effect, or which needs detoxification using these, which needs the help of a renal system, has to be avoided in these patients, wherein already the filtration capacity or the excretion capacity of the kidneys is less. So the diet chart is totally changed. And the S stands for specialty evaluation by a nephrologist, wherein the serum creatinine is normally more than 3 milligrams per deciliter. It has to be taken care by a specific nephrologist. So all these factors have to be taken care by a dental physician when he initially examines the patient, or there is initial general examination of the patient. So if he comes across any abnormality in these particular parameters, he immediately has to refer it to his physician so as to bring back these parameters to the normal level, thereby permitting him to do any kind of elective dental treatment. So that is the dental considerations. Acute renal failure, you can just forget about it. There is no way that you can touch an acute renal failure patient. He is not a candidate for any kind of dental procedures. Now there's a dialysis is a must for these kind of patients, and he has to be rushed to a dialysis room. On the other hand, chronic renal failure or end-stage renal disease, generally there are so many oral complications that there are so much of overlap in the oral complications that any particular dental treatment or elective dental surgery which has to be taken care, there are a lot of factors which have to be taken care of, starting from the poor oral health of these patients, the bleeding hematological disturbances and the electrolyte disturbances, the interactions of the medications which you give as a dental physician and the medications which the person is already on a chronic basis. So all these cases have to be taken care of, and among this, anemia and excessive bleeding are the most important factors which have to be taken care, especially by an oral surgeon. So all the adjunctive hemostatic measures, your emergency drugs should include DDAVP, also known as vasopressin, which has to be immediately available to provide any kind of hemostatic measure in these patients. Now, another most important kind of anticoagulant measure is your tranexamic acid, which is also which is an antifibrinolytic agent, which can be used and soaked up in a small cotton gauze and placed over the area with excessive bleeding. So these have to be easily available for the dental physician before touching any person with CRF or chronic renal failure. Also, the susceptibility of infection, primarily because of the low amount of RBCs or the low immunity because of the lack of basic blood within the body, or the increase in the nitrogenous waste, the immunity power of the blood decreases, and the person coupled with xerostomia, there is increased susceptibility to infections. So any particular dental procedure which can disseminate these microorganisms or infectious agents into the systemic circulation, primarily your bacteremia, resulting in endocarditis, that has to be taken care and avoided in these kind of patients before doing any elective dental surgeries. Now, to come to the end, the prescriptions, even the medications which we prescribe, have to be dealt very carefully, since most of the medications undergo first pass metabolism in the liver and excretion in the renal system. So since the renal system is not working properly, the excretory system is hampered, and the medications which you give can, instead of curing the patient, produce more amount of severe side effects, thereby resulting in toxicity of the drug. So there are many medications which are commonly given in the dental department which have to be avoided for CRF patients. Listed here are a few of them, such as if you see antacids, the most commonly given medications. If you look into the former GIT disorders and other GIT disorders wherein you give antacids as the first line of treatment, that have to be avoided in CRF patients because of the increase in magnesium content. Now, this magnesium content above a certain level can prove toxic to the patient instead of providing any use to the patient. Similarly, to penicillin therapy, which is one of the mainstays of antibiotic therapy, that increases the potassium content, but not to be used in cases of CRF, wherein the basic excretory system is hindered over here. Along with that, similarly carbonicillin, wherein there is increase of sodium content. So in all these cases wherein penicillin is indicated for that particular patient, you have to search for an alternative antibiotics which can do the same job without producing these side effects. Similarly, you have catabolic effects. Now you know anabolic steroids, tetracyclines have this catabolism which is not supported by this weak renal system. So that have to be avoided in cases of CRF also. And also few of the medications such as phenacetin or ketorolac, they have increased nephrotoxic capabilities, wherein it can further damage this renal cells instead of helping out the patient. So these are some of the medications which you have to take care of before prescribing it to a patient with suffering from CRF. So that brings us to the end of the most common disorders which affects the renal system and the GIT, and how a dental physician can overcome that to sufficiently treat the patient to satisfactory levels. Thank you for your patience. Thank you one and all.